Good morning, Dental XP viewers. I'm glad to be with you on the first day of the new year. Wishing everybody a happy new year, as this webinar is broadcasted all day for 24 hours as the sun rises all across the globe. I wish everybody a very happy new year, and I want to extend thanks to the Dental XP team, Dr. Maurice, Eddie, Tyler and Pana, and everybody that's doing a great job to make us connected globally. And I hope this new year we would find more peace in our lives and more achievements in our scientific and impact both on the local and global level in venues like Dental XP. This is my expert page on Dental XP. If you go to the expert section and click on Africa, you will find my page where you can see past presentation and look for the upcoming courses and lectures and be able to stay in touch together through this wonderful website. This is an image of my city, Alexandria, which is a very beautiful city located on the Mediterranean Sea. Lots of good sun and beaches, and I would invite everyone from our friends around the world to visit us and enjoy our time here. And Alexandria is not only known for the sun and beaches, but only for the rich history that goes for thousands of years. And this is a city that was found buried under the sea, and many archaeologists now are doing excavations to get the artifacts and the statues out of the sea, and others are still down there, like an underwater museum for those who love diving and love history. Also, for the new year, we will be happy to launch in the next couple of months 3D Vision, which is our advanced training center for 3D imaging, 3D printing, computer-guided surgery, and digital dentistry solutions, where we'll be happy to provide continuing education for the dentists from around the world and from our region related to the topics of CBCT imaging, interpretation, anatomy, pathology, 3D printing and advanced technologies, also CAD/CAM work, computer-guided surgery techniques and how to implement them in everyday practice, and 3D digital treatment planning, and also the different digital dentistry solutions. And to stay in touch, please send me on my personal email if you're interested in such courses, and we're gonna stay in touch together. For today's webinar, the content is very interesting, and we're going to start by intro to CBCT imaging. Then we're going to discuss the different navigation methods in the CBCT datasets, and then discuss the major anatomical landmarks that each clinician should be familiar with. Then we're going to go from the introductory section to the advanced section of advanced findings related to the TMJ and stylohyoid complex. And then we're going to take a look at very fascinating advanced applications in implantology and end by the conclusion. First, let's take an intro to CBCT imaging. I always like to say that CBCT has created a revolution. It allowed the transition of dental imaging from 2D to 3D, and thus eliminating the guesswork out of our diagnostic equations. No more there is any need for any clinician to guess that this is the cause of pain of this patient or not, or this might be the width or height of bone. We can base our diagnosis, our treatment plans, and our surgeries on facts and not fictions, on reality and not myths. And it also expanded the role of imaging from diagnostics to image guidance of operative and surgical procedures in what we call computer-guided surgery applications. And we've been doing lots of work in computer-guided surgery here, but today it's outside of the scope of the webinar to discuss it. Maybe in subsequent webinars or presentations on Dental XP, we're going to go in deep into the guided surgery world. CBCT scanners are simply, they look like normal panoramic scanners where the patient stands, and then the machine takes a 360 or sometimes less rotation around the patient and captures a volumetric image that can be seen in axial, sagittal, coronal, and 3D, where the clinician can move through the cuts and take a look at in depth of what the reality of the anatomy of the patient, and do treatment plans and diagnosis for the specific case. Cone beam CT was named after the shape of the geometry of the beam that emerges from the source into the detector, and it has the shape of a cone compared to regular multi-detector fan beam geometry. The cone beam geometry takes a rotation around the patient, and multiple cephalometric-like projections are taken that we call the basis projection. And then these basis projections are reconstructed by back projection algorithms into the regular axial, coronal, and sagittal sections, in which we're going to learn how to navigate through today. So, what did CBCT give us in extra of the regular CT in the 3D world? CBCT gave us a lower dose, approximately of 1.3 to 22.7% of an equivalent patient radiation dose, an accurate image of sub-millimeter isotropic voxel resolution that is very small, ranging from 0.4 millimeter to as low as 0.09 for some machines. And in the imaging world, we use the word pixel, which stands for picture element. But in the 3D world, we use the word voxel, which stands for volume element. And the CBCT voxel is what we call isotropic. The X and the Y and the Z are equal in size. In contrast with the fan beam regular CT, where the Z is unequal to the X and Y, which is the slice pitch, and which leads to more accurate reconstructions in CT with smaller units of resolution that allows us to see very small, minute details in endodontic cases, for example. Also, CBCT allows what we call beam limitation, which means collimation to limit the area to be radiated. For example, we can just image 2 or 3 teeth in a segment. We can do a quadrant imaging, a full arch, both arches, or full face imaging, which is very beneficial to just irradiate the area that needs to be exposed to radiation, which is of a great benefit and reduce dose to the patient. Also, the scan times are very quick, and this leads to less radiation and definitely less artifacts caused by patient movement. Also, CBCT equipment have a much reduced physical footprint and almost quarter the cost of the regular CT machines, which makes them friendly, lower dose, with accurate images, and that are readily accessible into a normal clinic and doesn't need extra preparation for it. Every CBCT machine exports its images in what we call the DICOM, which stands for Digital Imaging and Communication in Medicine. And these DICOM files are the language of interchange between different machines and third-party software. So we need to know the term, we need to know that we can image our patient with CBCT scans and then take the DICOM images and import them into other third-party software for orthodontic movements, for orthodontic surgery planning, for implant planning, or other advanced applications. I would like to quote also the position statement of the American Academy of Oral and Maxillofacial Radiology on the selection criteria for the use of radiology in dental implantology. And in their 4th recommendation, they state that the radiographic examination of any potential implant site should include cross-sectional imaging, orthogonal to the site of interest. And in the 5th recommendation, it is said that CBCT should be considered as the imaging modality of choice for preoperative cross-sectional imaging of potential implant sites. So after this very small introduction, I will go into the navigation, how to navigate into the datasets. And again, it's beyond the scope of this webinar to have a case of 2D versus 3D, or like establish a case of why do we need CBCT in today's world, because I think the case for CBCT is already established, both in research work and our clinical experience. CBCT is becoming a reality in today's dentistry, and it is good that we make it the standard of care for our implant planning and other applications, as we're going to see today. And of prime importance for us to learn the navigation in these data sets that we have. Both we need to learn it in 2D, the MPR, or in 3D, as in maximum intensity projection or volume rendering, and we're going to explain these terms shortly, along with the fly-through or endoscopy. So, as we said, CBCT machines don't give us like 2D plain films, but they give us a 3D volume, and we live in a 3D world, and we need to learn to navigate in the 3D volumes. And as a discipline, I stopped using panoramic films or even reading CBCTs or CT scans on printouts films. I take a look at, I open my CD that I get from the scan center, or the DICOMs that I import on my third parties. I navigate through the volumes and make sure that I see everything, and if there are things that I don't know or I can diagnose, it's good to refer to. I know I'm a fault. So the first thing to know about the navigation of CBCT volumes, that they can be done in 2D or 3D. In 2D, they can be done in what we call the MPR, or multiplanar reformatting, which is basically being able to move in the three orthogonal planes: the axial, the coronal, and the sagittal. And these are very important terms for every clinician to be familiar with, that you are able to move through your 3D volume up and down through the axial sections, back and forth through the coronal section, left and right through the sagittal section. And if we take a look at these videos, and this presentation will have lots of videos, because again, it's an interactive world, we don't need it to be static. And we see here on the lower left corner, I am moving up and down in the axial sections till the orbit, and then in the upper left corner, I'm going to move from the back, from where the cervical spine is, anteriorly. And then on the upper right corner of the screen, I'm going to start moving left to right through the TMJs and the sinus, the midline, and then the other TMJ. And on the lower right section, we see the 3D reconstruction that gives us a general idea of how the anatomy looks like. And again, in this presentation, I'm going to be using many videos to illustrate the interactive nature of the technology, and not just be content with just a slide with bullet points. So after learning to navigate in the 2D axial, coronal, and sagittal, we need to be familiar with the 3D visualization techniques, like the MIP, standing for maximum intensity projection, minimum intensity projection, volume rendering, and surface rendering. We're going to start by the maximum intensity projection, which is basically a 3D reconstruction of the volume resulting from CBCT machines that emphasizes the radio opaque or the bright high contrast objects like the fillings, the teeth. And in the clinical practice, it is extremely useful for evaluating the high contrast bright radio opaque substances like impacted teeth, for evaluation of RCT, evaluating implants, surgical plates, and foreign bodies, like we're going to see. For example, if we have our impaction cases, usually we take a look at the axial, coronal, and sagittal sections, but still we need to have like a mental image, a visual of the true orientation of our canines, for example, the relationship with the surrounding tooth. In that case, we need to use the MIP, which is the visualization that shows us the structure of high density, like the teeth, and emphasizes them. This is a 3D volume rendering of the case, and there is something in the midline that we can see clearly. So we switch to MIP, and now it is demystified. We can see a flipped and rotated central incisor. You can see the position of the crown, the roots, the relationship with the remaining dentition. We can have a more proper planning for the intervention in such cases. If we take a look at this panorama together, we're going to see that we don't have only impacted 8s, but we have also impacted 9s. And this is a very interesting case. And me personally, I would like to see the CBCT of such case before operating. The involvement of the nerve with the roots of these teeth and how to avoid injury to such cases. This is another case of an impacted 8 and 9 that are kissing, if I might say, and are involving the nerve bilaterally. Again, using the MIP, I can see the impactions clearly. I can see that they are involving the nerve, that their abnormal position, and I can plan my case accordingly. And this is a very rare case that we saw at the scan center. Also, MIP can be used for root canal treatment evaluation. In that case, we can see the root canal with the 3 puffs of sealer protruding into the sinus, and we can confirm it also, again, taking a look at the cross sections of this case. Radio-opaque metallic substances like the surgical plates are very well seen on MIP reconstructions, and also we see here during the capture of a post-operative scan for the patient after fixation with plates. This is what we see in the machine, and it is similar to the MIP concept. Also, implants are clearly seen, there's a relationship to each other in such views. A very interesting case that I'm going to show here of foreign body using the MIP technique. This is the gunshot case. This patient suffered a gunshot in his face. His anterior teeth were broken, and as we're going to see, this is the panoramic image with the fragments of this type of bullet on his left side. We zoom in, we can see the broken teeth. We're gonna take a look. Yes, this is the entry point of the gunshot, which caused severe injury to the teeth. Can rotate 360. If you notice also there is a fragment in a very high level, very near to the orbit. You can adjust the contrast of the MIP to emphasize more the fragments and the roots of the teeth. Can rotate, we see here the entry point where the bullet entered and it caused the fracture of the crowns of the teeth. We can use what we call an inverted filter on the MIP to emphasize more the fragments and the roots. We can apply also what we call the color mapping to assign colors to high density structures. Like in that case, everything that looks red is of high density is metal or enamel. Being able to visualize more, communicate more with the team and for referral. Second 3D visualization technique is the volume rendering, which is basically a 3D reconstruction of not just high opacity objects, but of everything in the volume according to a threshold. We can set the threshold to the soft tissue. In that case, we'll be able to visualize the patient's soft tissue. We can set it to the airways to be able to visualize the sinus, the airways in sleep apnea cases. We can set it to bone. And for example, this is the soft tissue threshold. We can see the profile of the patient. This is an interesting case. Usually when we think about CBCT, we think about the bone or teeth. But again, we can take a look here at the anterior profile of the lip of this lady. Can move through to where she lost the crown and have only a remaining root, and how this affects also the profile to be a little bit depressed. We can use also volume rendering to reconstruct the soft tissue profile of this lip or similar lips, and we can have an idea. Sometimes lips are depressed due to the loss of teeth, and we can later on simulate movements of the teeth or the bone and see their effects on such lip profiles. So it's good to have a mind also for the soft tissue, not just the hard tissue. Also, an advancement that we talked about in the last webinar is the superimposition of 3D images or stereophotogrammetry, where a 3D image of the patient is taken along with his CBCT and then superimposed together. We can see clearly his profile, his soft tissue contours, both in color and in shape. We can simulate orthognathic movements, orthodontic movements, and see their effect on the profile of the patient. We can use volume renderings to simulate the airways, like this case. And as we see, I'm going to go back again. We can measure the volume of the airways, and if sometimes we have constrictions here in sleep apnea case, we can diagnose it by CBCT. If we set the threshold to bone, we can view the general bony topography of such patients. And this is a video showing this very interesting case, which had lots of unusual architecture, bony protuberances, tori, both in the maxilla and mandible. Very interesting if you want to do shaping to these bony architecture for aesthetics, or if we want to harvest them for grafting. It's good to have an idea from the volume rendering. And also, if we take a look at the axial cuts and we go up and down, we can see this very unusual appearance of the maxilla here. And if we go down, you can see some tori also in the mandible. Another very important and interesting 3D visualization method is the fly-through, which can be used to see inside the mandibular canal, or can be used for what we call sinus endoscopies. And in this video, we are going to go through the canal, entering by the lingual foramen of the mandible and the ramus, going all the way through, and then exiting from the mental foramen. Very important technique if you want to visualize an implant impinging on a nerve. And we're going to publish an article soon on inferior alveolar nerve injuries with Dr. Howard Gluckman from South Africa, a very esteemed colleague and an expert in dental XP. After taking a look at an intro and the different 2D and 3D visualization techniques that the clinician or radiologist can use in CBCT, we'll take a look at an overview of the major anatomical landmarks that are very important to be known, so that we can take the guesswork out of the diagnostic equation. Also for the medical legal responsibility of having volumetric datasets. Whatever we image in the CBCT, we need to be able to diagnose or identify. If not, we need to refer to an oral and maxillofacial radiologist, because we are responsible for informing the patient of everything we see in the volumetric datasets. And definitely knowing the normal anatomy is of prime importance to detect the pathologies. And by knowing our 3D interactive anatomy and being able to read the CBCTs, we are able to prevent injury to vital structures during the surgical procedure and provide the optimum care for our patients. We're going to discuss in this section what we call the correlative anatomy, correlating the MPR, axial, sagittal, and coronal to 3D views, And a lot of the 3D models and some descriptions are courtesy of Dr. Wissam Al-Rawi, my friend from the University of Michigan, and this is his website. It's very interesting and very informative for anyone who wants to learn more about CBCT imaging and interpretation. We're going to discuss the 7 vital landmarks in the maxilla and mandible, and we're going to go through them one by one. We're going to start by the maxillary sinus, which is a very familiar landmark to many of us as an air-filled cavity situated in the maxilla, and we see it here in the 3D model, and here in the axial, coronal, and sagittal. It's usually pyramidal in shape with the base towards the nose and the apex toward the zygomatic bone. It's usually radiolucent and black, and healthy sinuses look like this one, air-filled, not fluid-filled. Sometimes you might find some similar structures in the sinus, whether here in the floor or related to the foramen here or on the lateral wall. Sometimes you will see like this scan, fully blocked sinuses bilaterally, which this scan was for a friend of mine that he suffered from sinus blockage for many years that affected his taste, and he needed surgical intervention to be able to clear that out. If we take a look at this scan in the maxillary sinus, we find that there is something like a lesion that caused erosion of the root apices of the maxillary teeth. If we go back again, find severe erosion of most of the root structure, and in case we see something like that, we need to stop. Usually on a panoramic image it won't be that clear, and we need to refer to an OMFR. Again, if we take a look at this sinus, the right one, you'll find this opacity related to the infraorbital foramen. Usually they are cysts, but again, if we're not sure, it's good to refer and take an expert opinion in this. If we take a look together at this OPG, do you see anything unusual about it? I think our eyes would go to the impacted third molars, but again, do you see anything in the sinus? Taking a look at the CBCT scan in the coronal sections, we find that the left sinus is totally blocked. And again, is this related to the impacted tooth, or has another reason, or is it an occult finding that we just found accidentally while going through our volume? We need to ask an OMFR for a report and refer to the proper expert. Application of knowing the anatomy of our sinus is very important in implant planning. In that case, we did planning for a full arch case, and here in the posterior maxilla, we made sure that on both sides this is the floor of the sinus and our implants don't violate it. Same in a 3D image. In case we don't use 3D imaging and are careless, like this case that came from another country presenting to the clinic to do his prosthetic phase of implant treatment, but he was complaining from pain in his left and right sides. So when we did our CBCT scan, we found this malpractice that I don't have a lesser word to describe. We find here implants in the sinus, unfavorable angulations, very close proximity to teeth. If we take a look at the cross sections, we find unfavorable angulations, violation to the sinus, again unfavorable angulation in the anterior maxilla, loss of bone. If we take a look at the 3D rendering, we find violation of the sinuses with the implants. Again, with the use of CBCT, we can avoid such misfortunes for our patients and for us. Second important landmark is the infraorbital foramen, which on the 3D here we see represents the opening of the infraorbital canal. And we see it radiographically as a round radiolucent opening situated in the superior border of the maxillary sinus lateral to the nasal cavity, as we see here and here. The infraorbital foramen dissection is of prime importance, and its position, especially when we're doing orthognathic surgeries, when we're doing zygomatic implant planning, we need to avoid its injury. And postoperatively, if this neurovascular bundle is injured, the patient will complain of itchy, tingling, and burning sensation, numbness, pins, and needles in this area of innervation. And these images are courtesy of my friend Dr. Stuart Orton-Jones. Another important anatomical landmark to notice in our CBCT scans is the Greater Palatine Canal, here that we see with the red dots on the 3D model. We need to take care of their position when we are doing connective tissue grafts, when we are harvesting them. We need to make sure that we're not injuring these vessels, and we can radiologically detect them here, as we see on the sagittal slices, by first locating this, what we call the pterygoid plate, and then identifying the radiolucent duct anterior to it. And on the coronal slices, it can be identified using the level of the vomer bone and the inferior nasal concha as a landmark. And we see here the canal, the opening of it, and this is its course in the palate. This is again a dissection. This is the palatal bone, and this is the greater palatine foramen. Another important landmark in the anterior maxilla and the midline is the incisive canal. We see here in the axial section as a round radiolucent canal. We see it here in the coronal sections and in the sagittal sections. We need to take care of it when we're doing dissection, raising our flaps, and when we're doing implant planning in the anterior maxilla, we need to avoid injuring such structure. If we take a look also here, this is an unusual bifurcated and large incisive canal, which can complicate our implant treatment in the anterior maxilla. So as I always say, we need to take care of the reality of the anatomy, which means that treat every patient as unique and check its proper anatomy before we place our implants in such patients. Another important landmark is the mental foramen, which is opening on the external surface of the mandible here on the 3D model, and is typically located in the premolar region, and it signifies the anterior end of the mandibular canal. And radiologically, it appears as a crescent, incomplete radiolucent circle here, as we see here and here. This is the opening in the coronal section, and we need to know it when we're doing tracing of the structure on our third-party softwares. This is dissection of the nerve. Now we go to the mandibular canal, which is a tube-like structure traversing the whole length of the mandible from the mandibular foramen and the ramus till the mental foramen in the premolar region. On the CBCT, it appears like a radiolucent circle here, surrounded by thin radiopaque ring, which represents the bounds or wall of the canal. It is very important to be able to identify it here on the axial slices, on the coronal or cross sections, and the sagittal, and when we're drawing our panoramic curve, seeing it on the thin sliced panoramic. This is a dissection again of the nerve, and it's very important when we're doing our implant planning in the posterior mandible not to impinge on the nerve, not to cause its injury. And again, if we take a look at this case, we see here the main trunk of the nerve, and if we move the slices, we see here that the nerve bifurcates into an upper branch and a lower branch. If we magnify the cross section, we see here clearly a bifurcated nerve. And the importance is if we do our tracing, taking in consideration that, okay, this is a normal single trunk nerve, and we plan the tracing according to the lower one, and then we place our implants, we're gonna injure the upper segment of it. So we need to take a close look, use inversion of colors, using color maps, and trace it and give it the attention that it needs according to the anatomy of the patient. This is another patient that came complaining of persistent pain in the lower right lip for a year now after implant placement, and the 2D OPG was inconclusive. Again, this is a case that will be featured in the inferior alveolar nerve article with Dr. Howard Gluckman that will be published very soon, hopefully. So we did the CBCT, we did the cross-sectional tracing of the nerve, and with the 3D reconstruction, we can see here this slight involvement of the nerve by the implant, which was enough to cause paresthesia for the patient for more than a year now. And last but not least are the genial tubercles, which are small round protuberances here on the lingual side of the mandible. And radiographically, they appear as a prominent radio-opaque spines, which are located at the lingual side of the mandibular midline, superior and inferior to the lingual foramina. You see here the lingual foramina entering the mandible lingually, and we see here again the foramina and the genial tubercle. We see the foramina of sublingual artery and other branches entering from the lingual side of the mandible. This is their entry points again on a dry mandible. And I want to make sure before placing my implants in the anterior maxilla that I don't cause any injury to such vessels, which, by the way, according to the literature, are not found only in the midline. They can find anyway in between the premolar and the premolar in the anterior mandibular region. And if our implants impinge on them, they can cause injury below muscle level, occult bleeding, and maybe suffocation of some patients. This is a finding that we need to take care of in our viewing of the 3D scans. This is another interesting case where the foramina are found in the midline and on both sides and are going through and through from the lingual side to the buccal side. Here on the cross section, we see two entry points, the upper one and the lower one, and they're going through and through till the anterior part of the mandible. Again, we can see two foramina here on the right and the left and on the midline. Anatomy is beautiful, but it is very different from what we learned in the anatomy textbooks. So we need to have a 3D paradigm for the reality of anatomy before we treat our patients today. Having gone through the intro into CBCT, the different navigation techniques, and the basic radiological anatomy on CBCT, we are going now to the advanced section of our webinar, where we'll discuss some advanced and often overlooked incidental findings. And we're going to start with the TMJ. Usually, many of our patients complain from clicking, from joint locking, from pain. And we're going to use this case to illustrate what we can see on CBCT 3D imaging for the TMJ. This patient came presenting with pain, and when we did the CBCT imaging, as we take a look in the upper left corner, we found the right condyle in the open position. If we take a look again, there is what we call subcondylar cyst formation here. There is erosion to the condylar head. There is loss of joint space. There is what we used to call in the literature bird beak appearance, which today we call lipping of the condyle. We can move through the sections, left to right, anteroposteriorly. We can see those cysts clearly. We can also use some VR volume rendering tools to visualize the lipping on the anterior pole of the condyle, the erosions, and all these findings, the subcondylar cysts, the lipping, are suggestive of osteoarthritis or osteoarthrosis to the joints of this patient, and will need the proper attention and referral. If we take a look at the closed position, we find there is a loss of joint space, anterior displacement of the right condyle, If you move through it again, we'll be able to notice subcondylar cyst formation and lipping of the condylar head. If we go anteroposteriorly, again we see the subcondylar cyst formation on the closed condyle. Again, if we go to the other condyle, the left one, we see again loss of joint space, erosion, subcondylar cyst formation, lipping. All of these suggestive of osteoarthritis in this patient, and they can be confirmed also by taking a look at the cervical spine if the field of view of our CBCT allows it. So if I'm not an expert and I see such findings, I can have an eye for them, refer them to an OMFR, and do the proper referral for the best of this patient. Another very interesting overlooked findings on OPGs and CBCT is what we call the stylohyoid ligament complex. We often hear about Eagle syndrome, and it was named according to W. Eagle, as we see here in this reference, that it described the elongated styloid process in 1937. And if we take a look at this OPG, which is my OPG, this is my mouth, and as you see here, I have very nice infections in the maxilla. One day when I need to remove them, I need to go to a very good oral surgeon. Okay, as we take a look here on both sides, we'll see what we call the styloid process that is found as a normal radiographic anatomy on OPGs and CBCTs. And Eagle described that the normal length of it is around 25 to 30 millimeters. If we take a look at this OPG, we see we see two things: a styloid process that is elongated, and a stylohyoid ligament that is calcified. If you look at the normal OPG, this is the normal styloid process, and no calcification of the ligament. It's normally radiolucent, and this is the hyoid bone. And here we see that the ligament is extended and calcified from the styloid process to the hyoid bone. If we go to cone beam CT of this patient, we can notice here this calcification of the ligament extending from the styloid process up to the hyoid bone. And usually such patients have symptoms and complaints of orofacial pain on swallowing when they turn their necks to the opposite side where the calcification is. Usually we can't find the cause. We keep on searching and searching and searching, and by doing the proper scans, we can find the nature of these calcified ligaments. Like we see here, this is our ligament calcified. If we take a look on another section, here the axial sections, we notice that the calcification has a lumen. And in the literature, we can find that the calcifications can sometimes be nodular, have a lumen, can be continuous with the styloid process, or like this case, independent of it. Again, another OPG showing an extensive calcification of the and enlargement of the stylohyoid ligament. We see here on the left side. Sorry, I'm going to go back to this. We see here on the left side an enlarged and calcified ligament. Here we see an enlarged process and then a calcified ligament. Again, this is another patient that came for a CBCT on his inner ear because he had a complaint of pain. And when we do our CBCT, we find again the incidental finding of a calcified ligament and also an enlarged styloid process. Here's the process. If you go through the sagittal cuts, you can see our ligament. We're going to adjust our plane of cutting on it. Very clear, very nice finding that might solve the problem of complaint of this patient. So take a look at the other cuts. You see it here again. Taking a look at the axial cut, we see here that it has a lumen, as we said, the pattern of calcification of this case. Another OPG showing a normal styloid process, but a calcified ligament here. Another case of a very elongated and calcified ligament and unilateral. On the right side you have nothing, on the left side you have. So these type of findings are incidental but are very important. 3D imaging gives us eyes to see them better and be able to diagnose better and give better standard of care to our patients. Going into the last section of our webinar, which is the advanced application in implantology, which is a very favorite section for me because it's fascinating what we can do today with the low-dose cone beam scanners. We can use them to measure bony plate thickness, measuring the soft tissue thickness and biotype, detection of periodontal bone loss, implant planning, simulation of donor and recipient graft volumes. Going into the first application, which is measuring the bony plate thickness. In this article by Alessandro Gionario and Barry Vieira and Lindy and this wonderful team from Brazil, titled Dimension of the Facial Bone Wall in the Anterior Maxilla, a Cone Beam Computed Tomography Study. Usually, in 2D imaging modalities like this periapical radiograph, we could assess clearly the interproximal height of bone. What about the thickness of the buccal plate anteriorly and palatally? How about the thickness of the soft tissue? We didn't have any info about that preoperatively. Now with CBCT, we can do the cross sections. We can see clearly the buccal plate thicknesses of such cases. Here we can see the attachment of teeth and bone. And as we see here, we did what we call the lip lift, which is a trick that I would advise to clinicians to use it, the lip lift or lip roll technique, when you put a cotton roll in the vestibule to separate the soft tissue of the lip from the soft tissue of the gingiva. And it gives you, this small trick gives you immense info. Here we can assess the soft tissue covering the graft. We can assess the graft volume. We can assess the buccal plate and the thickness of soft tissue on these incisors. Usually in the anatomy books that we studied, we have an image of the teeth inserted in the middle of the bone and having very thick buccal plates of bone. But the reality of the majority of teeth that we see on thousands and thousands of CBCT scans is that the buccal plates are very thin. And post-extraction, you're going to have very thin plates, and sometimes they will be deficient. And we need to know the behavior of these plates. And this is the case that I did lately and working on. On the left, you'd see the post-extraction site, and on the right, the comparison after doing a grafting of this site. If we go to the cross-section or coronal section, we're going to see here the buccal plate of bone on the left, and this is after grafting and membrane placement. I really want to know what will happen to this buccal plates of bone in ways that weren't available before. So what we're doing is we're taking images preoperatively extracting, putting the grafts, and we're going to measure exactly what happens to such cases. Another interesting application is from this article by Miyamoto and his team from Japan, which using the CBCT to analyze post-operative labial bone thickness in the maxillary anterior implants, and he compared in that case the immediate and delayed implant placement. So usually post-operatively we have this beautiful periapical radiograph. We can assess the interproximal heights of bone, but what about again the buccal plate of bone? Is it existent? Is it dehiscent? Did we do a good job? Will we have a problem later on? And with CBCT now we can see clearly the thickness in different levels and be able to assess it post-operatively. These are images courtesy of Dr. Abdulsalam Al-Askari, and it shows the buccal plate before extraction of root fragments, and then after placing the implants using certain grafting techniques, and the effect of these grafting techniques on the thickness of the buccal plate of bone. And here the lip roll showing the thickness of the soft tissue preoperatively and postoperatively. Again, these are very interesting concepts that are now available for us for clinical work and research work. So CBCT can be used to measure bony buccal plate thickness. Not just that, but also to measure soft tissue thickness and biotype. This is another article by the same team, by Riviera Junario from Brazil, which is a new method to assess and measure the palatal masticatory mucosa by CBCT. When we wanted to do a connective tissue graft, the only way that we could do it is by probing, anesthetizing the patient, trying to have an estimate about it. This team published a study in which they calculated the palatal masticatory mucosa using the CBCT scan. Again, so if you're doing a CBCT scan for your patient because you're going to place an implant and implant planning, it's very good also to take a look at the soft tissue, whether in the buccal vestibule with lip rolls or in the palate, to be able to assess will we have enough thickness of tissue to collect our connective tissue grafts from there or not. Also, this is a very nice article for measuring the thickness and tissue biotype and its relation to underlying bone morphology, in which CBCT measurements were very accurate representation of the clinical thickness of both the labial gingiva and bone. In research, usually we use such jigs to be able to measure and probe the same location during the different time periods of follow-up of the research. But again, today we don't need to poke our patients anymore. We can do the CBCT scan. And in that case, I want to illustrate the concept of lip roll between this image on the right and this image on the left. Here we have the soft tissue contour of the lip superimposed with the labial gingiva. But again, just placing a retractor or a cotton roll in the vestibule, you just elevate it, and now you can have a clear view of the labial gingiva, the thickness of soft tissue, the level of bone, cement-to-enamel junction, which is very valuable information. This is a case that on which I did a retreatment for endodontic failure on both the anterior teeth, and here is the temporary that I placed after replacing the very bad crown that had margins impinging on the biological width of this patient. Now doing the CBCT, I can see the margin of my temporaries, I can see the cement-to-enamel junction, I can see the margins of bone. I did the lip roll lift technique for this patient. I can see here where my crown, the temporary crown margin ends. I can see the thickness of the soft tissue. I can assess the height of bone. I can take my measuring tools and measure the thickness of the soft tissue to determine the biotype and have an idea of its thickness and its behavior after extraction sometimes. I can measure from the crown margin to the cement-to-enamel junction to be able also to assess my biological width. I'll be able to measure the thickness of my buccal plates of bone, all of this in one scan using simple techniques, having all this info that are very useful for my patient. Third advanced application is not only detecting the buccal plates of bone and measuring them, the soft tissue thickness both labially and palatally, but also the detection of periodontal bone loss. Both this article and the following one describing the evaluation of high-resolution CBCT in detection of simulated intraradicular bone lesions. They showed the success of CBCT for measuring furcation involvements and other periodontal defects. If we take a look at this OPG, for example, we can detect here the heights of bone are altered in the mandible. You can see this lesion. Some also loss of bone in the maxilla. That's it. I can see more in the maxilla than this, especially in the anterior region where the drawbacks of the panoramic projections appear. If we take a look at the CBCT of the same patient and its volume rendering, wow. We can see clearly the bone topography, the bone loss, in a way that wasn't possible before with the normal OPGs. We can put proper treatment plans, determine which teeth are hopeless, the exact amount of loss of bone, and being able to provide better treatment for our patients. Number 4 is implant planning. And I think now it is the standard of care to do CBCT imaging for even a single implant site. And it is very important to implement the concepts of implant planning using the 3D technology and using surgical guides. This is an OPG that shows a treatment plan that I don't want to have in my practice. Cantilevers, very close implants and failure of implants, screw loosening. I want to have predictable implant planning based on sound principles that I can do preoperatively on 3D scans and then implement on the day of surgery by surgical guides. So this is some examples of what I don't want to have, or what I can call malpractice. An all-on-3 bridge, and it's not even an all-on-3, it's an all-on-2 because the last implant is not even loaded. We don't want to give our patient such result. Another example is this patient coming for scan and having these 2 implants placed buccal in the premolar region. I don't have an explanation of such case. Like if you see at the axial, I don't know why these implants were placed that way. I don't want to put them that way. And if anyone has an explanation, can kindly send me on the rationale behind such placement. But again, our patients deserve better than that. This is an example of a treatment plan for a congenitally missing lateral case. If we see in the upper left corner, we rotate in the 360 degrees to check the relationship of this implant with the neighboring teeth. Again, we rotate around the implant to see from what direction. We rotate our 3D, and we manage to reach a proper treatment plan with a 3.2 or a 3 millimeter implants that will be placed next week using a surgical guide with depth control and full sequence. Again, this is another case for congenitally missing lateral that wasn't very lucky as the last case, because the orthodontist did more of a tipping movement, not bodily movement, which closed the space between the roots. And again, seeing them in 3D, as we see in this scan, I see that even a mini implant, a 2.5 implant, is not proper for such case. So I referred it back to the orthodontist to continue his work and have it ready on time for us to place it in a predictable and an accurate way. Another very interesting thing is this case that in which we placed an implant after extraction, and we did a CBCT in which we, here as we see, we noted the buccal plate, we planned our implant depth, we rotated all around, made sure that the buccal plate was preserved. We were able to go through the axial sections up and down until coronally we noted the jumping gap. We can get our measuring tools preoperatively, measure it, 1.6 millimeters. The literature say below 2 millimeters, no need to graft. This is what we're gonna do. Again, coronally it's less, it's 1.35 millimeters. So being able to see the gap and measure it accurately preoperatively is a very interesting and important info to the clinician. And we placed our implants using guided surgery in that same position, and we're going to take a post-operative scan in 2 months and see how this buccal plate acted. Again, in this case that was done using guided surgery, the implants was placed just on the floor of the sinus, and in our treatment plan we placed our implant for depth control a little bit lower. And on the day of surgery we did the drilling to the lower level, and then using the implant, which is self-tapping and self-threading, we were able to manage to attain the full depth of this implant. Excellent result, predictable, especially in tight situations like this one. This is a case in which 2 implants were placed very close to each other and then was sent for a post-op scan after, in fact it was a follow-up scan after 1 year. Here we did a lip roll for this patient. See here the implant in the floor of the nose, no buccal bone on the anterior. If we take a look at the other implant, okay, it's not in the nose, but we have loss of bone palatally and labially. Also, doing the lip roll, if we take a look at the soft tissue, clinically there was a dehiscence and due to the loss of bone between the 2 implants. And if we maximize the axial cut, as we're going to do now, we're going to find that we can see the dehiscence of soft tissue on our cone beam scan. See here clearly, go up and down, and see here where our arrow is, the dehiscence of the soft tissue anteriorly. And according to these info, we place our treatment plan, how we're going to best treat that patient. Another implant for post-operative scan, follow-up, no buccal plate, bone loss. All of this could be avoided now by proper planning and anticipation of where our bone levels will be. Last but not least application is the simulation of donor and recipient graft volume. This nice article published by my friend Dr. Scott Gans, which was I was lucky to do a workshop with him 2 years ago in Cairo. And the next case I'm going to show is following the same principle like this article. We see here a simulation for implant, but why did I choose to place my implant outside of the bone? This is where my main bone volume is. Why did I place my implant here? And the answer is because of the tooth. People come to our clinics wanting teeth and not implants. So I want to place my implants where my teeth will be, following the restoratively driven implant placement concepts. In that case also, you can see that I did a lip lift or lip roll, so I can see clearly here my depths of tissue to be able to plan the depth of my implant according to the 3 millimeter rule of emergence profile. And I wanted to be emerging in the crown in that direction, so this was the proper placement related to the buccolingual direction and depth of that implant. Again, the 3 millimeter of proper emergence and the proper position, and this necessitates to simulate a graft of bone, and here we simulated the volume, and the software calculates in CC how big is this volume if I'm using particulate grafts, or in that case if I'm using a block of graft, I can simulate the fixation screws. I can also simulate the donor site on the ramus of the mandible to be able to harvest the graft in a very safe way. This is how the case will look like with the implant, the cross section, the graft. This is a video showing the planning again. See how big is the concavity. This is where my tooth will be. I can do what we call cross-sectional clipping. I can move in the section and see the exact section below my tooth. How does it look like? I can simulate my implant in the right position. according to where the tooth will be. And accordingly, I can start planning my engineering for this site with block grafts and final case design, selective transparency. Again, very powerful diagnostic tools giving us eyes to see and being able to change our treatment plans, select the right armamentarium, the right course of action and treatment plan for this patient, and implement it on the day of surgery. And this is the powerful the power and beauty of this technology. So in the end, I want to conclude that 3D CBCT imaging is an indispensable tool in our diagnostic armamentarium, and that the knowledge of 3D correlative anatomy is of prime importance for the diagnostic and surgical procedure to prevent injury to vital structures. Advanced and incidental findings related to the TMJ and stylohyoid complex shouldn't be left unnoticed by our eyes. And advanced application of CBCT are very valuable and should be implemented in our everyday clinical practice and research like never before, and the time is now to go into new horizons using these tools. And as I always see, we are just seeing the tip of the iceberg. In the end, I want to leave the note with you about our training facility, offering CE courses in 3D imaging, 3D printing, computer-guided surgery, and digital dentistry solution. This is my personal email. You can contact me for the dates of the launch and different types of module and courses we offer. I want to thank, in the end, Dental XP team, and I want to thank my viewers, wishing everyone a happy new year. Go enjoy and celebrate, and a great year to come for everyone and for your families.